Good evening, everybody. I'm Dr. Alan Wasserman. I think I know many, many people in the audience, but for those that don't know me, I am chairman of the Department of Medicine at the George Washington University. My former chair, oh, there he is. My former chairman's in the audience, so I'm going to have to do a good job tonight. So I'll try to moderate this group. One of the things that one small housekeeping item is, when I've done this before, I find it very helpful to make sure that I'm asking the questions to the group that you want to know. So there should be pads that are going to be passed out where you can write some questions down. We'll collect them, they'll bring them up to me, and I'll take credit for them if they're good. And if not, then I'll read your name out. You don't have to put your name on the pad. But any questions you have at all, just put it down for us. We have a pretty distinguished group, a varied group. We have two geriatricians, we have a rheumatologist, we have an ophthalmologist, and a psychiatrist. And I'll let you try to figure out which one is which as we go along tonight. I'm going to let people introduce themselves, but I'm going to start off by asking them a question and then ask them to just tell us a little bit about themselves as they start. And I'm going to start at that far end there with Dr. Cooper. Jim, basically I wanted to ask you and get this started with not the most uplifting subject, but probably a subject that's on everybody's mind. What is dementia? Is dementia one thing? Is it all the same? Is it... why don't you tell us a little bit about it after you tell us who you are?
I'm Jim Cooper, and I'm the director of the Memory Disorders Clinic at GW. And the question, I think, is, what is the difference between dementia and Alzheimer's and all the other terms, senility, that we throw together? And they all seem to be similar. First, let's get rid of senility as a term that we use. At least we don't use it in science because we don't know what it means. Senility is a term that's been around, 100 years or so, and it has different meanings to different people, so we just discard that. Then, if we had PowerPoints, I was told I couldn't use any PowerPoints here, and as an academic...
You can use shadow puppets, though, if you want to.
As an academic, I feel kind of naked without the PowerPoints, because we use them so much. And if you will imagine that there's a white screen behind me and the first line across it is dementia. And that's the categories, dementia. And then under that category are the different kinds of dementia. And the first kind of dementia that we would talk about, the most common, is Alzheimer's dementia. That's maybe 60% of dementias in this country are Alzheimer's. And then underneath that, just for completeness, we would say there's vascular dementia, second most common, probably the most common dementia in places like Japan, where they have so much high blood pressure. And then the more interesting types of dementia, like frontal lobe dementia, dementia with Lewy bodies, and so forth. But that would be it. Dementia is the overriding term for a progressive, deteriorating disease of the brain, and the most common kind is Alzheimer's.
Is dementia inevitable, Jim?
Is it inevitable?
Yeah, we all going to get demented if we live long enough, or is there ways to avoid it?
Yeah, well, I can answer that. If you live long enough, you're going to get dementia. And nobody can deny that and argue with it, because if they die without dementia, I'd just say they didn't live long enough. But people who know more about this than I do say that probably for people who live their natural life into their 90s, 70% or more will get dementia of one kind or another.
I'm going to move down to Dr. Katz. And Jim, after you tell us your role at GW, there's a re-emerging controversy over the use of calcium. And so many elderly women are on calcium for preventing either osteoporosis or fractures. And the question is now, is it a good thing? Is it a bad thing? What is it?
I'm Dr. Katz. I'm the director of the Division of Rheumatology at GW. Calcium and how we manage our calcium and how much we get is a daily topic in rheumatology. It's become very important because They did some interesting studies about children not getting enough calcium in their diet. The IOM looked at how much calcium kids should get, and if you think about it, it's pretty scary that teenagers get only about 25% of the amount of daily calcium that they should be getting. As a result, it's very possible that we've developed a community of adults who have insufficient amount of calcium over their lifetime and now are playing catch up. We know that it's amazing, but our bones are dynamic tissues. They're not just dead calcium sitting around. They are turning over and rebuilding themselves in response to everyday stress all the time. In fact, your spine is totally new over a period of 4 to 5 years. That's how dynamic bone is. In order for that bone to rebuild itself in response to everyday stress, you have to have the right nutrients and substrates. You have to have enough calcium. You have to have enough protein and enough vitamin C, among other things. So if you have grown up with insufficient calcium, you never achieved peak bone mass. And if you don't have enough calcium in your diet on a regular basis, you can't supply the nutrient needed to rebuild bone, because that is what bones do. They repair against everyday stress.
Psychiatrists often use short-term memory as a test. What are they using it for, Lorenzo? Are they using it for, not really for dementia, was they use it on people of all age? How does that fit in with dementia?
All right. Again, when psychiatrists are using short-term memory as a test, particularly what Dr. Wasserman is referring to, a psychiatrist might speak to you and they ask you these brief screening questions. Those are screening questions that can be, if you will, suggestive of something else going on, whether it is a dementia or also whether, more to the point, whether there's something going on that's interfering with your memory, which could have a variety of causes. Some of the medications that you take, particularly if you're taking sleeping medications such as Valium, can interfere with your memory. Depression, clinical depression, can actually cause memory problems that can look like, the term used to be pseudo-dementia, but we actually prefer to call it cognitive impairment secondary to depression. It's not Alzheimer's or vascular dementia, but what you do have is a disruption of your cognition due to this clinical depression. When psychiatrists are testing for that short-term memory, they're looking for a variety of things that could be causing problems with it, but not necessarily specifically doing the intense testing that might be required to diagnose a clinical dementia.
I want to come back to that, but Sam, I want to get back to you for a second and talk a little bit more about the eye. I mean, macular degeneration is a fear of us all. Has there been any advances in treatment of macular degeneration, and there are different types of macular degeneration?
That's a good question. That one I was anticipating because it's on everybody's mind. Particularly in the last decade, there has been huge strides in the treatment options for the wet macular degeneration. I think everybody's familiar with the dry and wet kind. The dry macular degeneration is what is out there 80% of the time. If we were to sample the population, 80% of patients who have macular degeneration have the dry kind, which is like a dry rot of the retina in the center. The wet kind is when the blood vessels start to, in the back of the eye, penetrate to regions where they're not supposed to be and start bleeding and leaking. Now, in that stage, there's been huge advances, particularly in pharmacotherapy. New agents, a lot of you, I'm sure, have heard of Lucentis and the Avastin. These are administered by intraocular injections, actually giving these as little injections in the eye. I can tell that's a very popular delivery method, but you'd be surprised how well tolerated it is. But these work very specifically at inhibiting abnormal new blood vessels and leave the normal vessels alone. And it's thanks to our oncology colleagues that we have these drugs. And Alan, you're familiar with the factors that these antagonize. But that has been the major stride. And later on this year, they're going to release another compound that also directly inhibits the growth of blood vessels. So in that sense, there's a lot of new agents for the wet kind. Now, here's the kicker.
And is treatment earlier better? I mean,
Yes.
is, okay.
Yeah, and that's one of the things, when I was finishing my fellowship in the early 90s, we never talked about gaining vision in macular degeneration. We would do things that seem pretty primitive. You'd use laser beams to essentially cauterize the portion of the retina, and it's no different than amputating in a case of gangrene, where you're going to try to save the major part by getting rid of the smaller part. But earlier the better, as far as visual recovery and also long-term stability.
Jim, 80-year-old male comes to see you with back pain, most common etiology that you see, and of course you rush right to get an MR the first time you see them.
Back pain is one of the most common reasons that patients come to the outpatient clinic at most ages, but it really escalates in terms of the cause of a visit around the age of 70 and above. And our backs can hurt for all sorts of reasons, and we commonly blame it on degenerative arthritis or osteoarthritis. It's very common. I can find it in almost anyone over the age of 45 if I look hard enough by X-ray. But we really don't understand what about this degenerative arthritis is so uncomfortable. Why is it that way? One particular bugaboo for patients as we get older is that the arthritis tends to crowd the spinal canal, called spinal stenosis. And when nerves in the spinal canal don't have enough room, they complain and they make themselves known. Patients with lumbar spinal stenosis have trouble straightening up in the morning. They'll tell you that when they go to the grocery store, they need to lean on the shopping cart to go up and down the aisles. It's a kind of insidious, deep pain that they have difficulty describing. We don't have the words for this kind of pain. It's not like a bee sting pain. And if it gets very bad, it can even affect how far you can walk or bowel and bladder function. Early on in disease, it's something that you can fortunately treat with physical therapy. Physical therapy and the right exercises can go a long way to opening up the spaces in the back and making enough room. And if you are diligent and stick to your therapy, that can go a long way to helping avoid other kinds of interventions like shots to the back or even surgery. Now, many times it's so common we don't need to even do an X-ray. We can tell just on physical exam. But back pain should be evaluated in the rare case that it's due to something else. If you get better with physical therapy, then we encourage that you do that as long as you can to forestall that day when we have to be more aggressive. Fortunately, in the right patient, surgery, when you have to resort to that, is very successful, and it can really improve function.
And there's an intermediate step that you could try, at least with minimally invasive injections into the...
For sure, there's a lot of intermediate steps before surgery. Injections, just the same kind of injection that you do for a pregnant woman in labor, can be done for a person with back pain, but in giving steroids instead of numbing medicine. And that can be done safely as long as it's not done too often.
What about living wills and power of attorney? Where does that come in?
Apart from the paperwork, which is very important, and making sure that the legal affairs are in order, the key thing about your preference is that you make sure that the people who will be called upon to make decisions for you are aware of what your preferences are. It turns out that people have no idea what their relative, loved one, good friend would have wanted. It comes out worse than chance. Would your spouse wish to be on a ventilator? Would your best friend wish to have a feeding tube? It turns out people have no idea what their closest, the people closest to them would want. And so the very important thing is, if you have ideas about what you would want, make sure that you discuss it with the person who's likely to be your decision maker.
Good. I want to thank our panelists. I want to thank everybody. I know I didn't get to everybody's questions. I'm sure our panelists are going to be able to stick around for a while, so if you have some individual questions that I wasn't able to get to, I'm sorry. Please come up and ask them directly, and thank you all for coming tonight. I appreciate it.